Well, welcome everyone to the regional conference set. I'd like to first of all just extend my thank you to Julie McCormick and the team for instigating these regional conferences, which I think are a fantastic idea to get the messages out there to the regional areas and to the agencies. A very, very important part for the people of Victoria and the communities in Victoria that are receiving dental care and oral health care through Dental Health Services Victoria. So thank you very much. And it's a pleasure to be part of the inaugural regional set of conferences as well. My presentation today is around models of care. It's going to discuss the philosophy and principles of models of care and bringing some reality of those models of care into everyday public dental care, and I'll have some clinical scenarios that may be useful to you and sort of examples of how models of care is really a concept. There's no one size fits all, but certainly models of care are something that we need to consider. I've got there an obligation to consider change, an appropriate model of care for your group of patients, your profile of patients that you are treating every day in your local communities. An overview of my presentation is first of all the definition of models of care, because models of care has been bandied around for a long period of time, fairly common terminology within the medical fraternity for many, many years, probably less common in the dental area. I'm going to talk about the need of a model of care and models of care, and what we're talking about in the need for change, and looking at what we are doing at the current time, how we're actually delivering our services. The evidence also to support models of care change, challenges and hurdles that you may come across in instigating any model of care change, and the adoption of appropriate models of care into your community dental service. First of all, the definition. Models of care, I won't read it fully, but the key words are a different way to approach that. We're looking at a patient journey, we're looking at describing how patients receive care, which is critical. We're looking at what care and who will provide that care, and the better health outcomes and more people than ever before. So we're looking at numbers, we're looking at the outcomes, we're looking at who, the team, who makes up the team, who's providing that care, and also how they'll receive that care and what we're going to provide in that care. So first of all, the key questions that coming out of that definition are what services? For example, models of care, say in the Scandinavian countries, a model of care in the public dental service is just emergency and health promotion. Their taxes are very high, so they've decided to do nothing other than provide emergency care, relief of pain and suffering for the local people, local communities, and also health promotion, because as we all know, most the common oral diseases, both periodontal disease and caries, dental caries, are preventable. So we've got to look at what services, and that can vary from area to area. So the communities that you're serving out there in the oral health arena certainly will vary from place to place, and obviously the social gradients and social determinants of health come into play of what services you are going to provide. We're looking at why we provide these services and in a specific way. Currently, what you're actually doing at this current time, and what you could do or should do in the future. And who to? Who are you going to provide it to? I mean, your profile might be, teenagers, or your population profile that you're serving young children, 0 to 5. You might say, well, we're going to concentrate on a model of care specifically for that group and provide a different model, different type of care or different service to teenage groups, say 18 to 25, and the ageing group. Others might have there's the population ages. It might be that you concentrate on the older age group, and you develop your model of care around that. How you're going to provide your model of care, how you're going to provide it, what workforce you're going to use, the extended workforce, what processes and systems also are you going to introduce and develop to assist you in providing that model of care to the appropriate group. I've got down there must utilise data. You've got to know your community profile. So data. I mean, that's a big word, a big thing today. You've actually got to know who makes up your population, who you're providing the services to prior to developing any model of care. The need for models of care, we're looking at a primary healthcare team approach, which involves a bigger team than just the oral healthcare team. We're looking at the medical team, the allied health team, and the extended medical team. I think when you're looking at oral health and dental diseases now, to be provided just by the oral healthcare team, I think is a problem and a significant issue in the current environment with which we're working in. We've got to look at the need being a patient, not a tooth or teeth focused process. We're looking at a population outcome. We can't just look at an individual tooth or the mouth. We've got to look at treating the whole patient. And I'll talk about this further on when we talk about chronic disease components of oral diseases. We cannot continue to deliver more of the same. I mean, ultimately, I always say, you know, the service that's being provided principally across most jurisdictions in Australia now is the private sector model. That sort of, I say quite crudely, the bum on seat model. You know, the patient has to come in, get treated and go out. I think we can't continue to do that same. That private sector model is very valid for the private sector, and that's a model of care that works for the private sector but certainly doesn't work for the public sector. Certainly because of the ratios of dentists and therapists and oral health therapists to population, as well as the need to look at the disease as a chronic disease. So we've got to look at the broader primary healthcare team, the first dot point. We're looking at the broader team delivering services and programs to individuals and to populations and communities rather than just having to see the patient. We're looking at oral health workforce to population ratio, and that's what I was saying, that the ratios of dentists. In a private practice, you've got one dentist around about to 2,500. That works well. That's a model of care that works well. You put them on recall and they keep coming back. You can manage their oral health and you manage their general health as well. That's a good ratio. Certainly not the situation here in Victoria or across Australia. So the model that we have to look at has to use the broader team and look at the disease, the oral health diseases, both dental caries and periodontal disease as chronic diseases. And we're also looking, because now we've got workforce diversification and scope of practice expansion, certainly the options and the opportunities are certainly there to use the broader workforce to look at managing the oral diseases. This is a slide and a form that you may or may not have seen. It's a chart showing a public dental model of care. I've got the next couple of slides, I'll split them into two, but you'll see the top section is talking about the principles, where we're minimising the impact of poor oral health on the quality of life. And these are the principles that you take into account when developing any model of care. We're looking at patient-centred, they've got to be cost-effective, multidisciplinary, appropriate evidence-based, accessible, equitable, safe and high quality, evaluated and monitored, population health approach, got to be preventive, innovative, use of technology and early identification of risk and disease. And the centre section of the slide is the public dental model of care, which is looking at public health interventions. We're looking at other programs at antenatal programs, we're looking at school programs, we're looking at adult programs. Then the lower part of the slide is where the patient journey begins. But I think as we talk further on with my presentation, there's a flow back. Although the flow doesn't work across the top and then down to the second section of the slide, there's an integration, it's a circular pattern rather than just a pathway from childhood through aged care. We're looking at integrating the public dental model of care into the clinical journey all the way through. This is the first section, talking about the principles, which are the key principles for any model of care. The top section, the lower section under the principles is the public dental model of care. We're looking at the public health interventions, the T1, the water fluoridation, and then you go into the antenatal and school program, adult programs, and then at the right-hand side of the screen we say the patient journey, clinical journey begins, and we move into the next slide. But as I said, the patient journey begins, and that's the clinical journey, and that's when you actually see the patient, but there's always a flow back. So while the patient is going through its clinical journey in any model of care, you flow back into the other programs that are occurring both at the community level and the population level. You can flow back. Obviously water fluoridation is occurring throughout the clinical journey. There are other programs in the slide previously that you can link into, you can link your patients into. The need continued. Chronic disease outcomes are required to be supported by preventive maintenance programs, the PMP. PMPs are a critical part of any chronic disease management. So whether we're looking at diabetes or cardiovascular disease, any chronic disease, we're looking at preventive maintenance programs. And certainly this is the same in oral health. You must have preventive maintenance programs to invest in the work that you've done in the surgery and with your patients and with community. Preventive maintenance programs are a key part of any model of care. The increasingly pressured health dollar, I mean, we talked about cost effective, and this is a very important part. I mean, there's only so many dollars in our system here in Australia to go around, and it's being increasingly pressured. So that's certainly a part around the need to looking at models of care. We can't, the health dollar is not expanding, therefore we've got to look at doing things more effectively, efficiently, and just doing things in a smarter way. We're going to look at management of the oral environment rather than the single tooth. We're looking at the oral environment as part of general health, and leading to the last point, a need to reduce the overall burden of disease. So managing the oral environment rather than just a single tooth. We're managing the oral environment for the individual. We're reducing the overall burden of disease on an individual or a community. So if we're looking at diabetes, which has an inflammatory impact on individuals, we manage the oral environment of people with diabetes, which reduces the overall burden of disease on that individual. Right, the need continues. Some more points on the need. We need to, there is a requirement for us all to capitalise on significant resource investment of intensive oral disease end-stage treatment. And I'm talking about here any restorative care, any endodontic care, any crown and bridge work. We need to invest on that. That's hugely resource intensive. So we need to have a model of care where the investment we put in a community, in an individual and a community in doing these high cost and resource intensive end-stage treatments, we need to invest and we need to capitalise on those. And I've talked about preventive maintenance programs, and that's again, that flows back. We need to have a preventive maintenance program, one of the key parts of any model of care. You need to have an effective and efficient workforce utilisation, including education, clinical and non-clinical, both from a point of view, certainly here in Victoria, we've got universities training an oral healthcare team. We need to efficiently and effectively use that full workforce, from prosthetists, dental assistants, non-clinical as well. We're looking at triage systems, we're looking at call centre systems, we're looking at phone triaging. All individuals beyond the oral health team can be utilised within your model of care. And we're also looking at a demand increase. Certainly with the ageing population, people living longer, we're finding there's going to be an increase in demand. So with a pressured health dollar demand increase, you can see that we cannot continue to do more of the same. We need to really think hard and consider our options to change, because if we're going to improve, going back to the definition, we're looking at health outcomes for a greater part of greater numbers within the community, we've got to do things differently. So I think there's an obligation here for us all, both here in the city but out in the regional areas, knowing your community and developing models of care which are going to produce those health outcomes, both from an oral health perspective but also from a general health perspective. The evidence. I think the common oral environment disease are now considered chronic, and that's quite a well documented statement now. We're looking at both periodontal disease and dental caries as chronic diseases. So we're looking at a model. We're looking at models of care, and you'll be looking at models of care in your areas. But keeping in the back of your mind, or in the front of your mind, really, that both dental caries and periodontal disease are chronic diseases, not acute flare-ups. We do have acute flare-ups in chronic disease, but they're not just a one-off treatment process. It's not like replacing a knee or replacing a hip. Once the procedure's done, it's finished. Then you go through a rehab, and that's the end of the story. Chronic diseases begin at birth and they end at death. Chronic disease management requires a combination of individual, community and population approaches, and we've talked about that in that slide with the flow through from the public, looking at starting at water fluoridation, antenatal, preschool and adolescent, and then flowing through to the clinical journey. We must always looking at, that's the flow from the individual to the community and population. So you may see someone, but that's not the end of the story. It's what happens in the community, it's what happens at home, it's what happens in their population, in their day-to-day life that's going to make or deliver the health outcome that you need, and therefore that's what you've got to develop models of care around. Dental caries and periodontal disease outcomes depend on disease process activity fluctuations, and this flows back when we're looking at chronic disease. So both dental caries and periodontal disease, chronic disease, it's a process that's just starting at birth, ends at death, as I said, and you have acute flare-ups. If you don't control that chronic disease, you end up with cavitation for dental caries and tooth loss and attachment loss in periodontal disease. So the process is happening every day with us all, and we get acute flare-ups, and that's when we get breakdown in hard and soft tissue. So the models of care we're looking at is flattening out that process so that you don't get those acute flare-ups and having to intervene, filling cavities and removing teeth that attachments have been lost significantly. Social, dental and medical comorbidity affect and impact on the disease process, influencing care planning and priorities. So certainly the social determinants of health, we're looking at previous dental experience, we're looking at medical comorbidity, affect and impact the disease process. So as I said, from birth to death, you've got a process happening. So we're looking at obviously socioeconomic status, we're looking at previous dental history, we're looking at medical comorbidity. I mentioned diabetes, stress, just general stress on life. Stress creates increased inflammatory markers, which can also, and then we're looking at obesity, which also creates a stress on the body. So stress is a broad term that can create increased inflammatory markers and therefore affect what's happening in our mouth. Oral health improvements occur synergistic with improvements in the social determinants of health and management of common risk factors. So we're looking at smoking, obviously smoking a very obvious common risk factor, and the social determinants of health. Certainly with socioeconomic status, the lower socioeconomic status we've got, the more likely they are to have oral diseases or the acute flare-ups, and the process that's happening in their mouths has an endpoint of tooth loss and cavitation. So we've got to understand that any model of care that you're developing, if you're looking at your profile, going back to your data, looking at a profile that has you've got a low socioeconomic status of group, very low socioeconomic status profile within your community, which we're looking at healthcare cards, but there are groups which are very borderline. You could find that the difficulties in actually managing the oral environment is quite difficult, because you can't actually improve someone's oral health without looking at it's like it's a huge tide pushing against you. So you're working against a lot of the social determinants of health. We're looking at other social and medical comorbidities that are pushing the tide against you. So you've got to understand that whatever model you come up against, you've got to be realistic in what outcomes you're going to achieve. And in that first slide, we talked about all you can really achieve a lot of the time is the impact on quality of life, on someone's daily quality of life, that their oral health is going to impact in a minimal way. So that's what that statement's all about. So it may not be the pristine, perfect mouth, but you know that you're providing to your community a service and a model of care which is going to minimally impact on their quality of life. So their oral health is at a point which fits in or is appropriate to their way of life and their quality of life. Again, PMP significantly improved definitive intervention outcomes. We're looking at preventive maintenance programs. With chronic disease, again going back, like I bring up the diabetes, preventive maintenance programs happen in diabetes all the time, and that's where the diabetes is actually managed as a chronic disease. It's the critical part of any model of care. And these can be intensive, moderate, and just the low levels of preventive maintenance programs, a review and reinforcement. We've also got to look at the primary healthcare team. We're looking at an oral physician concept. Now this is specifically for the dentists as an oral physician, using the broader team, both the oral healthcare team as well as the broad allied health team and medical team in their communities, to actually look at the oral physician, not doing everything for the patient, not actually treating and doing, and that's a problem with the way we're all educated. We were taught to drill and fill and do examinations, hole there, cavity there, take x-rays, fill. We've got to move away from that and guide the team towards managing an oral environment of an individual and then linking them in to other programs within the community. So that's the picture that I'm trying to paint here today. We're looking at coaching, motivational interviewing, health message reinforcement, all key parts of managing a chronic disease. So the patient comes in, it's not only what you say to the patient when the patient's in there, it's what happens. 99.9% of managing the oral environment happens in the home environment, happens in the community. You can guide them when they come in, they only see you for a very short space of time. So the coaching, motivational interviewing, we're talking about the low-grade PMPs, the review reinforcement. It might be a non-clinical person ringing them up and seeing how they're going. How are the messages that the dentist and the oral health therapist told you yesterday going, or last week? Are you able to get that toothpaste? You know, is the toothpaste that was suggested? You know, how are you going brushing your 3-year-old's teeth? Little things like that. That's that reinforcement. And these are key part of models of care. They make a huge difference. It's not the patient sitting in the chair, you examining them, saying, "Oh, I got no cavities." That's not the issue. People say, "Oh, no cavities, I'm all okay." It's not that. It's the message that yes, there's disease in there. There's no cavitation. There's no holes at the moment. There's a process happening there, and and you're walking along a rope, and we want to keep you on that rope and not falling off. Minimal intervention dentistry, the MID care phases. I think this is important. Minimal intervention is certainly appropriate for any model of care. We're looking, that's certainly the philosophy and concepts of any model of care. The MID philosophy and concept certainly needs to be taken into account when we're talking about a model of care in 2015. So we're looking at chronic disease models of care are the most appropriate. So any model of care, we're not looking at acute, and we're not looking at a model of care for hip replacement, knee replacement, as I said. We're looking at a chronic disease management models of care which include individual, community and population interventions. And again, I stress common oral diseases are processes, beginning at birth, leaving us at death. They're there all the time. No one is without a level of disease. We've just got to control it and stop it going to an end point where it's going to affect your quality of life, which is through tooth loss or pain or suffering. It certainly can be managed with the broader healthcare team and community and daily home care. PMP directed at daily home care, and ultimately that's where the reinforcement with any PMP, preventive maintenance, whether it's done in the surgery, whether it's done on the phone, whether it's done on posters or on TV or media, it's directed at daily home care, because that's the critical part, what someone does at home. It doesn't matter if it's diabetes or oral health, it's what you do at home to manage that disease process, both dental caries and periodontal disease, that matters. Health literacy is a key part. We're looking at, is required to exceed the social scale 3. At this point in Australia it's 41 nationally to maximise models of care outcome. So if we're looking at a social health literacy scale of 3, you need to exceed the level of 3 to actually make your model of care work. So that's where you're actually looking at health literacy to raise it above 3, to actually 3 or above, to actually make to realise the outcomes of your model of care or to improve the outcomes. At the moment it's only 41 nationally, and I think we owe it to our communities here in Victoria to raise that health literacy, to understand what's going on, to understand their body, to understand their mouth. If less than social scale 3, the step-down interventions can be utilised as transitional or maybe even as final management. You might find that in some situations health literacy is very low, and this can be in certain very high-risk groups where the health literacy is extremely low, and it might be just chewing some chewing gum, some xylitol chewing gum 3 times a day, and that's all you can actually do. The actual use of a brush, the use of interdental brushing, the use of dental floss is not going to work. So ultimately your interventions will be very minimal, and that's all you can manage. Ultimately, to actually raise the literacy, ultimately your game is to raise the literacy so that you can move up the scale in your preventive maintenance programs and messages. But quite often in certain groups within your community you might find that your health literacy is very low, and then you then align your preventive maintenance programs to that level of literacy. The challenges: we've got a culture of internal and external dentistry is isolated from mainstream. We're looking at internal within the dental sphere itself and external. Dentistry has been isolated from mainstream health for many, many years, and I think any model of care, we're looking at a chronic disease, dentistry's been out there, it's trained quite separately, it's been, the mouth, even general practitioners, medical general practitioners, they say, oh look, it's a dental problem, see your dentist. They're a key part in any model of care to understand what's happening in their oral environment and how important their oral environment is, or how the oral environment reflects their general health. Undergraduate education. There has to be some significant changes in that area, I believe, because it's quite tooth focused, and we can't get away from that as well, because ultimately there are end stage points of a disease process where a tooth needs to be filled or extracted, or endodontic therapy needs to be done, or a crown placed. But there's quite a strong emphasis on that area and on that technical component, the drill and fill component. But certainly the issue of managing the whole oral environment and managing the whole patient as part of a community or along with the other primary healthcare team is very, very important. Marketing, information accuracy. I mean, at the moment with the internet, online, what's available online, both here and overseas, it's a challenge to actually develop a model of care which may not be the glossy online advertisement for bleaching teeth or veneers or implants. Mandatory versus elective concept. This is a very big issue. I mean, what is mandatory in health system? I mean, you might say that a lot of dentistry is elective. I mean, a lot of orthodontics may be elective in the sphere of oral health. You might say that a crown in certain circumstances is elective, not mandatory. So we're looking at the mandatory versus elective. So ultimately we're looking at mandatory first off in managing mandatory interventions within dentistry to actually minimise the impact of oral health on general health, as I've mentioned before, and the elective comes later, or sometimes in the public system in your communities in a model of care, not at all. That's something that's a decision that you have to make. That's something that, as we say, the health dollar is pressured. Maybe the elective components of dentistry in your area are not done. Dentistry as a business versus healthcare, and certainly that's out there on the online and on the web. There's a push from dentistry not being healthcare, and I think we've got to think hard that dentistry is healthcare and not a business. Funding models, Commonwealth and jurisdictions. Certainly the Commonwealth and jurisdictions, the funding is around item numbers, item number driven health funds, focus on waiting list reduction and activity. It's all about, someone is on a waiting list, someone comes off the waiting list, you fill their teeth, you extract, you do endo, you make dentures, and they're off the waiting list, and that's it. There's a focus too much on waiting list reduction. So they'd say a waiting list reduction has gone down, or waiting list has reduced by 10,000, in a month. Everybody's happy. From a political point of view, that's happy, and maybe I'll be speaking heresy here, but I believe that we should be looking more at waiting list management. So if a waiting list goes up, I don't have a problem with that. If you're actually managing the oral environment and a community's oral health and general health, that's great, because you need everybody on the list, and they need to be on the list, they need to be managed, they need to come on and off the list and get preventive maintenance programs, but everybody stays on the list. They don't ever go off the list. So I think you actually report on what you're actually doing with the people on the list is more important than looking at numbers. So these are the challenges. Numbers go up and down. It's that model of waiting list reduction. Oh, we've done so many hip replacements, and that we've reduced the surgical waiting list. That's a point in time. It's not managing chronic disease as we're trying to do here and you're trying to do out there in your communities. Absence of consistent oral health dental advice at national level, again, that's I think an issue. Oral health and dental advice at a national level is just not there. It's left as fragmented programs and views and issue managing chronic diseases. Certainly with states and territories, it's not coordinated and quite fragmented. We're looking at a new workforce working effectively. That's a challenge. We're looking at a new workforce both in the allied health. We're looking at expansion of scope of practices. We're looking at the allied health and medical health. We're looking at nurse practitioners. We're looking at, but right across health, there's an emerging new workforce, and we've got to get them working effectively together and looking at oral health as part of that whole general health. The second-rate dentistry view. So, this is a battle that I've had in my career, which has been significant for many years, this second-rate dentistry. When I've talked about models of care and doing mandatory versus elective, we're looking at stabilising someone's mouth rather than doing the definitive care initially, and managing a chronic disease, stabilising someone, rather than jumping into the crown and jumping into the porcelain veneer and jumping into bleaching and jumping into endodontic treatment. They see that as second rate, and I don't see that. I see that as it's the wrong word. It's an emotive word. I think the word is, what we're trying to do with models of care is provide appropriate care. And I think even in a private sector, appropriate care has to happen. And I think, in a private practice model of care, I think also, elective versus mandatory. The mandatory has to be done first. Maybe the elective is not done. And maybe the elective is only done at certain stages. And a focus on a duty of care. What's our duty of care to a community and a population? Is it just doing a relief of pain and health promotion? Is it doing fillings? Is it doing extractions? Is it doing all the high technology work, the implants, the crowns, the veneers? So this is a challenge. What is a duty of care that we have in the public dental arena for our community? An understanding of the accountabilities of a public system. We have we talked about, we're funded by the taxpayers' dollar. We have an accountability for the money we spent. So I believe the model of care that you develop out there and think of developing for your communities out there, you've got to be accountable. You've got to develop the system and look at a model of care which is you are accountable in the dollars that you're actually spending. And I think when you're looking at all the levels, the individual, community and population, and looking at disease stabilisation and model of care versus jumping straight into definitive care, capitalising on high cost end stage treatment, restorative, endodontics, crown and bridge work with preventive maintenance programs, very, very important. Adopting the models of care principles to service delivery, the overarching aim is to adapt the adaptation of the principles into all service delivery areas. We're looking at the negative impact of the oral environment and disease on the overall quality of life, as we talked about in that first slide, as an overall statement. That's what we're aiming to do. We're not trying to make everyone with the Hollywood smile. We're looking at a public healthcare model of care. We're utilising interventional preventive stabilisation or self-managed guided approach delivered by the complete team. So the key words that we're intervening in a chronic disease or a chronic disease process. We're preventing the acute exacerbations of a chronic disease process. We're stabilising a chronic disease process back to that rope, back to that centre line. And we're looking at self-managed and guided approach. We're guiding someone in the home delivered by the complete team, both clinical and non-clinical. Just some clinical examples now. Here we have a little girl, a very sick little girl. Tip of the iceberg here, very swollen face, doesn't look well. She has got a very high fever, swollen right face, and here we are, a very serious situation with an upper deciduous canine, a non-vital upper canine, with an acute exacerbation of the non-vital upper canine, upper deciduous canine, which in this situation is serious, can go up into the cavernous sinus and eventually lead to death. But this is just the tip of the iceberg. It's not, we're looking at a bum on seat situation here, tooths out, but this little girl, this is quite rare. You might have seen this in your communities, but certainly the tip of the iceberg. Why has this occurred? Certain pain and suffering has to be addressed first of all, and manage and certainly protect life. And certainly that tooth has to come out and that little girl has to be stabilised. But certainly following on from that, your model of care needs to look broader than that, and that's what I'm talking about. It needs to capitalise on that. We don't want this representing in with one of her siblings or another tooth in her mouth. We need to engage other members of the team to actually look at why this has happened. And that's not the dentist or the oral health therapist, that's the broader, that's the medical practitioner, social workers, other groups, to actually get a good, strong medical, dental and social history. Again, adapting the principles and the concept of model of care at all patient entry levels, the team approach to model of care pathways. So we're looking at no matter when you see a patient, whether they come in off the waiting list, whether they come in for emergency care, we're looking at the full range of your oral health care team. The dentist, the oral health therapist, hygienists, dental assistants and your students, if you have students in your area. So here are the entry points. We're looking at the emergency and urgent care, we're looking at general care, general anaesthetic waiting list and post-op. Preventive maintenance program, both from the aggressive, when we're looking at an aggressive preventive maintenance program, through to monitoring and coaching. So the little girl beforehand, you probably look at why has that occurred. You probably look at an aggressive preventive maintenance program, managed hard so this doesn't occur again. Then you taper it down to monitoring and coaching, but you ease off until you feel that the process in her mouth, in her family, in the community is under control. So you look at, it doesn't matter when the patient comes into your community agency, into your clinics, it doesn't matter what point they come in, you use the same principles and you can use a team approach to your model of care. Consideration awareness of utilisation of all intervention levels when adopting the model of care, and as I keep saying, that individual, the community and population levels, very important. They need to all link in. There's arrows going from individual to community and population and back up again. The population level never disappears, and the community level is very important when you're actually treating an individual or family to link them into any community program that's required, whether it be medical, whether it be dental, other dental, or whether it be social. It's extremely important. Remember, we're not treating just the tooth or just the mouth. Here's an example. A patient of mine I saw quite a while back now, a methadone program, endpoint. The treatment here was just all teeth had to come out. But this was a methadone program, so my model of care, I looked at this as, this is ridiculous. This patient had already tried to commit suicide twice, was a brittle diabetic, was in intensive care, huge cost to the system, and they couldn't understand why. This patient, he was in significant pain. His blood sugar was all over the place because of this infection. This inflammatory markers were through the roof. His blood sugar couldn't be controlled. He was on antipsychotic drugs as well as the methadone. He wasn't taking any of the medication. It was all because of his mouth. It had destabilised his whole system. So my view on this, that the endpoint treatment here is taking all those teeth out, but that's not the end of the story. We then developed a model of care for methadone program. You don't want this to happen. You don't want these patients to be a burden on the health system with intensive care and general anaesthetics more than once or twice. You want to actually get into the program. You develop a model of care for methadone program. And the health literacy in some of those can be high, can be low. You might be raising the health literacy of some of the methadone program. That might be all your aim, and that might be all that you're going to do, but you don't want it to get to this point. So your model of care is chewing your xylitol gum. It might be over the phone. It might be oral health therapists, might be dental assistants going out on a regular basis, but not a bum-on-seat model. We're not looking at that. These patients quite often don't look after their mouths. They're not going to pick up a brush all the time. All they can do is chew some gum. If that's all they can do, that's better than ending up like this and a huge burden on society. So that's just an example. Methadone program that I had in New South Wales, in my community, and we developed a program. So we wanted to reduce these acute exacerbations, which we did. And it was very simple. We didn't have to see the people. It was not done by dentists, and it was done by interventions which were very simple and straightforward. Another patient I saw, this was in Tasmania, a young female, 22 years old. So you look at that mouth and you think, well, first of all you think, the way we were trained, you just dive in and think, gosh, there's a whole lot of cavitation there, we have to fill all those, look how bad that is. But the way we look now from a model of care and looking at the principal's point of view, you say something's happening with this young girl. She's 22, she has a mouth like that. You think, well, the mouth is a mirror of the body. The US Surgeon General said that the mouth is a mirror of the body. No truer words did she say. This is back in 2000. That says a lot. You look at that, doctors look at that and they probably prescribe antibiotics. And I'm being facetious there. But we've got to change that, and that's another topic. But they've got to look at that, and that's just a signal that something's going wrong, both medically, socially, and certainly this was an unmarried mother. She was a victim of abuse at home, significant issues. So the model of care here is not dive in and restore those teeth and extract. This girl needs to have relief of pain, and it's not second-rate dentistry. This is dentistry that this young woman needs in her life at the moment. So no infection, reduce the burden of infection on her whole body. We need to stabilise her mouth, and that means if she's got any teeth that are aching, yes, they are managed, extracted or managed or stabilised, and the rest of the caries and decay, the cavitation, the acute and cavitation component of the disease process needs to just be stabilised. So we don't go and spend a whole lot of resources and time. We first of all start with DAs, dental assistants. We start with oral health therapists. We start with the doctors. We engage social workers. The big team comes in. Your model engages this. So you don't dive straight in. You look and you talk. You get a thorough medical and dental and social history, and you work through with this individual. And you're actually going to reduce the impact of her oral health on her general health and her quality of life, ultimately. So she was categorised in Tasmania, we called it urgent, which was probably a category 2 here in Victoria. She had pain on the 2-6. Going back to that, it doesn't show it there, but she had pain on the 2-6 with additional generalised caries lesion. I'm being understatement there, generalised caries, that's like sort of rampant caries. Primary care team management, we get a medical, social and dental history. Oral health therapists, we use oral health therapists to actually get that. Doesn't have to be a dentist. They're very good at communicating with the patients. They're trained well. We use the team. Radiographs, DA Cert 4 or oral health therapist. Proposed plan, clinical pathways, the whole team then decides with the dentist as the oral physician. Not team leader, oral physician we're talking about here. I think we're looking at an oral physician to actually engage the team, and they develop their the clinical pathways. The pain was in the 2-6, so the LA was given by the OHT, not the dentist. The 2-6, the palatal canal, could have been either, we're looking at, depending on whether the tooth was wanting to be saved or extracted, could be done by a dentist or a student. But the pulp of the one canal was just removed. So you don't remove don't spend a lot of time on it because you don't know whether the tooth's going to be extracted. You just remove the palatal canal, dress that, pain's gone, or you extract the tooth. So this is removing the pain and suffering of that young woman first and foremost. You seal and close that tooth was done by the oral health therapist, dentist or student. So one of the team, there's 3 members there that could do it, and certainly you could do this in your area. It doesn't have to be the dentist to actually seal off after an emergency extirpation. Then the patient, general stabilisation, you refer back to that care plan where the oral health physician dentist, they work together with the team that develop a plan. Could be done by the student oral health therapist or student oral health therapist or the dentist. So we're looking at general stabilisation. We're looking at just stabilising her mouth so that the disease process doesn't progress any further from a cavitation point of view. You utilise glass ionomer, silver fluoride, orthodontic bands, Keresolve and ultra-slow dentine removal. Again here, another situation. Cavitation, don't dive in. This is a picture of what's happening in that person's life, not a bunch of cavities. That's what we've got to think of. It's bigger than just those cavities. Those cavities are crying out, telling you a picture and a story of what's going on in this person's life. Using fluoride varnish, which the DA would apply. Home care, initial home care by the DA oral health therapist. Xylitol gum, interdental cleaning, toothpaste, diet. All those messages are given by not the dentist, but one of the members of the team. Most likely the Cert 4 DA or an oral health therapist. Pain relief, review and management. The oral health therapist dentist, you review and make sure the patient is not in any further pain. You've stabilised, and you get the dentist to review all pain and review the x-rays that have been taken by your Cert 4 DA. You refer to your medical general practitioner or community programs if appropriate. The young woman needs some support in the abuse area, and certainly the issue of managing her mouth and cleaning her mouth on a daily process was not high on the list. She was not going to brush her teeth. So these are the things we need to get things right in the social aspect, and then when the priority of oral health care rises on this individual's list or your patient's list, then you move down that pathway, but not until they're going to be receptive to that monitoring and coaching on how you manage your mouth, because there are 2 bigger issues going on in their lives. The relevant clinical pathway to appropriate waiting list, query a specialist referral if required. This is down the track. You reappoint for stabilisation. This is this managed waiting list, so you don't worry about waiting lists going down. You stabilise. Everybody on your waiting list has a stabilised mouth. So you report to government, I have 10,000 on my waiting list and they're all stabilised. How many was it reduced? No, it hasn't reduced. It's still 10,000, but they're all stabilised. And they're coming on and off appropriately to their care and what they actually need. That's our model of care. Your PMP, aggressive, review and in-house phone. So aggressive, first of all, with that girl, we might get them back and fluoride varnish and keep working on it because you're not going to do it at home. You have to be aggressive in surgery. Not with the dentist, DA, putting on varnish and varnish. Follow up at home. How's she going at home? How's everything going? Not necessarily the dental thing, but following up, being empathetic towards what's going on in her life, and again, saying, we know that her mouth was sort of really a reflection or a part of what's happening generally in her life at the point in time. Another mouth, again treated, again a picture of the body. Probably not quite a shiny mouth, periodontal disease, alcoholic liver diseases patient. So bigger pictures happening here. So your model of care, don't just dive in and fix up teeth. You bring in the team, and then the investment that you do in their mouth is realised. If you just fill teeth, just extract teeth, just make dentures and do nothing else, don't put them on a program, that money, those resources, those dollars that have been utilised fixing this mouth up are not realised. They fail. They fail within 12 months or 2 years. In the paediatric GA area, that's another area which is very important. You're looking at treating the whole patient, the whole family unit, not just the patient, which is an aim. Your model of care is aimed at preventing readmission of the individual and reducing your sibling admission. Your family unit is waitlisted. In Tassie, we used to waitlist the family unit. If we had a child that came in and had to have a paediatric GA, we'd waitlist that whole family. That whole family would become acute in our model of care, and we'd aggressively manage the whole unit, not just that one child. So that one child was managed by the oral health therapist, but you managed the family unit, the parents. If there was one or two, or just their primary caregivers, we actually manage that, because quite often, once you manage that whole unit was a problem. And so your investment is to the family unit, which is realised with your siblings. And it's done by your primary healthcare team, your DA and your OHT. All contact modes utilised and considered necessary. So that's your phones, your DAs, your oral health. Phones are perfect. You just have to do a 5-minute call. How are they going? It's amazing. Just reinforce if you brush your teeth. You're struggling. Yes, they're struggling. So quite often they might go out and do a visit and, oh, I don't even have a sink. You know, some of the patients in Tasmania didn't even have running water, you know, in some of the very remote areas. And we worked out how to actually brush the child's teeth and where they could go and set up programs. Appropriate pharmacological products mailed in selected cases. Quite often they weren't able to afford it. We mailed out toothbrushes. We mailed out fluoride toothpaste. Key messages, motivational interviewing done by the DA and oral health therapist, and also non-clinical individuals and employees. Post-op, initially aggressive, PMP1, high risk, representation, siblings similarly high risk. So anyone who's on a GA, a paediatric GA, we consider aggressive. We aggressively manage that individual, the child as I said, plus also the siblings. We aggressively manage them and the family. Your little girl, GA list, mouth looking like this. These are the mouths we look at. We don't just do the GA, send them away. The preventive mode program is aggressive to the individual, to her, but we manage the family aggressively as well. Because if one of the siblings' mouths look like one of those pictures, when they present and we organise a GA, we don't want the processes happening in the family unit. It's not just an individual process. And we don't want this. We don't want them going in and having GAs. We want to reduce the number of presentations of that individual. So your success rate is no readmission for the individual, for the little child, and no admissions for the siblings. So the way forward for all of you in the model of care, you've got to look at a planning and development phase. Look at your data and look at what's working and what's not working, what you're investing in and what you're not investing in. You look at the areas, units and facilities for possibly trialling concept. You might look at trialling a different model of care in a key area in your agency, out there in your community. And you might start small. It might work, it might not work. You might think, oh, I've got to change it, I've got to tweak it, I've got to fine tune. That's fine. It's just getting the concept across and changing and making some changes, because we have to make some changes. We can't continue. I think public dental care in Australia will fall over if we continue to do what we're doing. We need to change. We need to be responsible. We need to be responsible for the public dollar we're using and treat oral health disease as a chronic disease. Introduce a pilot research program in your area. You know, see how it goes. Work across agencies, work across areas. See what works in what network. And I think there's a public oral health the Public Oral Health Leadership Council now is a perfect forum for that. See what works, see what doesn't work, and report back. And then evaluating, a key part. You've got to evaluate on what's happening in your area. If it works, as I said, you evaluate. Don't just think it's working. It may not be working. You might think, well, it's not working in that area. You might change from 0 to 5 to age, or you might move from age to child care. Or you might have models of care for both. You might have just a model of care for emergency treatment because you see high levels of those. You want to reduce the levels of representations for extractions, or you can't manage your emergency presentations. So you look at a different model of care for that. So I think it's crawl before you can walk. It's a concept to take on board, and it's very rewarding when you look at when you evaluate and look at the data and you look at the results in your community, and it's very rewarding to actually treat the patient as a whole and as part of a whole team. It's a very rewarding feeling as a health professional. Review, modifications to the palliative delivery, as I said, one size doesn't fit all. What happens in one area, once you're looking at data, doesn't work across to another agency. We're looking at your data. What works, say, here in suburban Melbourne won't work out in rural Victoria. You've got to, but the philosophy and principles need to. So the philosophy, principles and concepts and the definition, those key areas of the model of care definition, you need to take into account and you need to adapt those to your model of care. But what you do in your area could significantly vary to another area. But the thing is that the principles and concept doesn't, and you'll be benefiting your community in changing the way you actually view oral health and oral health diseases and public dental care, and integrate it into the community, into the population, and to the social and just generally the well-being and quality of life of your local community. Thank you very much.